Welcome to Pathology Central Key Concepts. The topic of this video is the pathophysiology of neurodegenerative diseases. Now, there are a number of neurodegenerative diseases, but the goal of this video is to focus on the pathophysiology, clinical features, and morphologic findings of 3 of them to provide a foundation for you to understand neurodegenerative diseases in general. First, I'd like to address the concept of dementia. So dementia is a clinical syndrome characterized by impaired memory, changes in behavior, and perhaps loss of language skills. Dementia may be due to neurodegenerative disease, but there can also be other causes such as trauma, toxins, or infection. Furthermore, not all neurodegenerative diseases lead to dementia. So break that link when you think about this, that neurodegenerative disease is associated with dementia. And I'll explain some of the ways in which neurodegenerative diseases can manifest. Now, neurodegenerative disorders have some common characteristics. Very often, they will be due to the accumulation of protein aggregates. These protein aggregates can cause synaptic loss, which is responsible for the symptoms that we see in these disorders. Over time, we can get progressive loss of neurons, and we don't always understand the mechanism between how these protein aggregates cause synaptic loss and how we get our progressive loss of neurons. A further point I'd like to make is that there are proteins that may be involved in multiple diseases. So, for example, tau, which is a microtubule-associated protein, is seen both in Alzheimer's disease as well as frontotemporal lobar degeneration. Now, the symptoms will depend on where these lesions develop. These protein aggregates will typically affect groups of neurons with shared functions. So if we see lesions in the hippocampus and associated cortices, we can get cognitive changes such as disturbances of memory, behavior, or language, and over time, this can progress to dementia. Lesions in the basal ganglia are associated with our movement disorders. This can manifest as hypokinesis, so we see that in Parkinson disease, or hyperkinesis, so excess motion, for example, in Huntington disease. Lesions in the cerebellum as well as the input-output tracts lead to ataxia, and the motor systems can also be affected, leading to weakness, difficulty swallowing and breathing, such as can be seen in amyotrophic lateral sclerosis. So how do we get the development of these protein aggregates? There are really 2 pathways that we consider. The first is we have some sort of mutation in the gene that encodes the protein and thereby either alters protein conformation or disrupts protein processing and clearance, leading to the protein accumulation within cells and/or the extracellular space. Another possible pathway is that we develop an imbalance in protein synthesis and clearance due to a combination of environmental and genetic factors, leading again to accumulation within cells and/or extracellular space. So how do these protein aggregates cause disease? So it is thought that these large aggregates are likely not harmful. It's the smaller aggregates, these oligomers, that are particularly resistant to degradation and somehow cause damage, perhaps by activating the innate immune response, by direct toxicity to neurons, or by interfering with normal cellular processes. We have observed experimentally that we can get the seeding of healthy brain, so we can get interneuronal spread of these aggregates from one neuron to the next, leading to disease spread. This is a table from Robbins and Kumar Basic Pathology that nicely summarizes the various diseases, the clinical pattern, as well as the protein inclusions or deposits that are seen in each disease. Let's begin with Alzheimer's disease, which is the most common cause of dementia in older adults. Incidence increases with age, and while almost all cases are sporadic, about 90 to 95% of cases, familial cases account for 5 to 10% of cases and have been particularly useful in elucidating the pathogenesis of this disease. In Alzheimer's disease, we have 2 primary lesions, the formation of extracellular A-beta plaques and the deposition of intracellular tau, which is a microtubule-associated protein. Through these 2 lesions, through unknown mechanisms, we get neural dysfunction. Now, I'll be talking on the next slide more about A-beta. It is a peptide that forms the core of neuritic plaques, which we see in Alzheimer's disease, and can also be deposited in arterial walls. The clinical significance here is that we only see A-beta in Alzheimer's disease. We don't see this in other neurodegenerative disorders. The other lesion is intracellular tau, which accumulates in neuronal cell bodies and processes and can, through unknown mechanisms, cause damage. And if that neuron dies, this tangle of fibrils will persist after death, leading to extracellular tangles. So while it begins intracellularly, we can also see it in the extracellular space. And unlike A-beta, which does not correlate with the extent of dementia, the extent of tau does correlate with the degree of cognitive impairment. So let's turn our attention now to A-beta, which is a 42 amino acid peptide generated from the amyloid precursor protein APP. APP is also the name of the gene that encodes this protein. You can see this image here from Robbins and Kumar Basic Pathology showing this transmembrane protein. There are 3 potential cleavage sites for alpha, beta, and gamma secretase, and depending on where we get cleavage, this will determine whether the resultant peptide is amyloidogenic or non-amyloidogenic. So if we have cleavage at the alpha and gamma, this does not cause disease, but at gamma and beta, we will get our amyloidogenic peptide. I just would like to point out that the gamma secretase complex is a complex of multiple proteins that includes 2, presenilin 1 and presenilin 2, that we can see mutated in familial Alzheimer's disease. We'll come back to that later. So how does A-beta cause problems? Well, A-beta is highly prone to aggregation. We can get the formation of small oligomers that may go on to form large aggregates. These are seen in our plaques, as well as fibrils. Again, it is thought that the small oligomers are the ones that cause the most damage, injuring neurons by interfering with mitochondria or other organelles, impairing synapse function through unknown mechanisms, leading to memory decline. And they also contribute by causing the hyperphosphorylation of tau, thereby contributing to our neurofibrillary tangles. A-beta deposition is specific for Alzheimer's disease, but as I mentioned, plaque number does not correlate with the extent of dementia. So here we can see again our protein, and with this cleavage here with alpha secretase and gamma secretase, this is non-amyloidogenic. What we see by contrast is when we get beta and gamma cleavage, we get the A-beta peptide, which is amyloidogenic. Let's put this in the context of a really nice figure from Robbins and Kumar Basic Pathology. This one's a little bit busy, so let's simplify it. Here we just have our protein, which has been cleaved here with beta secretase and gamma secretase, yielding our A-beta monomer. This A-beta monomer can either form large aggregates, which we can see in our plaques and amyloid fibrils, or it can form these oligomers that through uncertain mechanisms cause neuronal damage, as well as impair the synapse, leading to memory loss. This brings us to our second important protein, which is tau. So as I mentioned, tau is a microtubule-associated protein. It's found in the axons. When we get hyperphosphorylation, it decreases the ability of tau to bind and stabilize microtubules and allows it to form aggregates that will form these neurofibrillary tangles. We don't know the exact mechanism by which these tau aggregates cause injury. Perhaps it's through a stress response leading to cell death, or maybe these destabilized microtubules contribute to neuronal toxicity and death. And again, the extent of neurofibrillary tangles and the loss of synapses will correlate with the degree of dementia. Let's focus here on the left side of this figure, where we can see our microtubule with our tau protein associated here. With that tau phosphorylation, we're going to get microtubule disassembly, which is thought to contribute to neuronal damage. And then this tau itself will form these tau aggregates, these neurofibrillary tangles, that while intracellular here, with the death of this neuron, can then be found in the extracellular space. There are a number of genetic risk factors for Alzheimer's disease that may be either causative or confer some degree of susceptibility. So causative mutations include mutations in our APP gene, as well as in the genes for the gamma secretase complex proteins presenilin 1 and presenilin 2. We can also see increased APP in patients with Down syndrome. This is because the APP gene is found on chromosome 21, and the majority of patients with Down syndrome therefore will have 3 copies of APP, which leads to an earlier presentation of Alzheimer's disease in these patients. In addition, there's a susceptibility locus. We know that the ApoE4 allele is associated with increased generation and deposition of A beta. This leads to an increase in an A beta independent and tau-mediated neurodegeneration, which is through a slightly different pathway. And we know that the increased dosage of this particular allele is associated with increased risk of Alzheimer's disease as well as earlier onset. Morphologically, we're going to see cortical atrophy, predominantly of the frontal, temporal, and parietal lobes. And because of this atrophy and loss of brain parenchyma, we will get hydrocephalus ex vacuo. There are 3 microscopic findings that we can see: neuritic plaques, neurofibrillary tangles, and cerebral amyloid angiopathy. These neuritic plaques are going to be seen most commonly in the cerebral cortex, hippocampus, and amygdala. And they're characterized by spherical collections that have an amyloid core, A beta core, with dystrophic neurites, so the axons and dendrites, that have tau aggregates. Neurofibrillary tangles are going to be composed of our hyperphosphorylated tau in paired helical filaments that can persist after cell death. And for our cerebral amyloid angiopathy, we can get A beta deposition in vessel walls, leading to an increased risk of hemorrhage. Here you can see an example of a brain from a patient with Alzheimer's disease. The meninges are retained here, but here where they've been stripped, you can appreciate the narrowing of the gyri and the widening of the sulci. This histologic image shows us some of these plaques. You can appreciate one here at the arrow as well as one here. This one is perhaps a little easier to see. You can see there's a central core, and there's also some these almost fuzzy, convoluted projections. These are those dystrophic neurites surrounding the amyloid core. And if we do an immunohistochemical stain for A beta, you can see that it's at the center of this lesion that we get that A beta deposition. This is an example showing neurofibrillary tangles. It's a little difficult to discern the neurofibrillary tangle here. I'll show you a better image of higher power on the next slide. But I wanted to use this image because it shows some important features. One are these extracellular neurofibrillary tangles that are the residua of ghost neurons. So as a neuron died and disappeared, this is that tangle that remains. Here's a viable neuron, and you can perhaps make out a little bit of a tangle here. Again, I'll show you a better image on the next slide. We can visualize these tangles using a silver stain, which you can see here. We can also use immunohistochemistry. I'll show an example of that in a moment. But first, just this very high power view showing this beautiful neurofibrillary tangle within this viable neuron. This is our hyperphosphorylated tau. And while it can be difficult to appreciate these in the neuron, again, here's a neurofibrillary tangle surrounded by ghost extracellular neurofibrillary tangles. We can use tau immunohistochemistry, nicely highlighting that tangle. But also you can see here we have a plaque, and this is some tau in those dystrophic neurites. Our final histologic finding for Alzheimer's disease will be cerebral amyloid angiopathy. You can see here we have a significant intraparenchymal hemorrhage, and if we look histologically, you can appreciate that the vessel walls are thickened and have this somewhat glassy appearance. We could visualize the amyloid using a Congo red stain, or here using immunohistochemical stain for A beta peptide. This brings us to the next disease I'd like to address, which is Huntington disease, an autosomal dominant movement disorder characterized by degeneration of the caudate and putamen, as well as symptoms related to involuntary and jerky movements. This disease is relentlessly progressive, and patients typically will die about 15 years after diagnosis. Now, this is a triplet repeat expansion disease, and what we see in Huntington disease is an expansion of the CAG repeat, which encodes glutamine, in the gene that encodes Huntington. This protein, Huntington, has an unknown function. We know that in wild-type individuals there are 11 to 34 copies of this repeat, whereas we get pathology with increasing numbers. And as those numbers increase even further, we'll get earlier and earlier onset. This is referred to as anticipation. Expansion of these repeats occurs during spermatogenesis. Now, with this expanded protein, we're going to get ubiquitination and proteolysis of this mutant protein, but it can't be complete, and we're going to end up with these large intranuclear aggregates. We don't know the mechanism by which this causes harm. It is thought this is due to a toxic gain of function, perhaps related to sequestration of transcription factors, disruption of protein degradation pathways, or perhaps perturbation of mitochondrial function. The most dramatic finding we will see in Huntington disease is atrophy of the caudate nucleus and putamen. We can also see some atrophy of the frontal lobes, and as we saw in Alzheimer's disease, we will get a corresponding ventricular dilation. Microscopically, we'll see neuronal loss as well as intranuclear inclusions of ubiquitinated Huntington protein. So let's look at those gross findings. Here you can see a brain from a healthy individual with a very abundant and well-formed caudate and putamen. By contrast, in this individual with Huntington disease, you can see that the caudate and putamen are quite degenerated, and the ventricle has correspondingly widened. Now, it can be difficult to recognize neuronal loss on a section, and it can also be very difficult to recognize the inclusions without the use of immunohistochemistry. This is showing a stain for ubiquitin, highlighting this little aggregate here within the nucleus. This brings us to the final disease that I'd like to discuss, which is Parkinson disease. The characteristic finding in Parkinson disease will be loss of our dopaminergic neurons in the substantia nigra, leading to a hypokinetic movement disorder. The severity of symptoms will be related to the extent of dopamine deficiency. Now, Parkinsonism is the constellation of symptoms characterized by diminished facial expression, sometimes referred to as masked facies, stooped posture, bradykinesia, rigidity, tremor, pill rolling, etc. Parkinson disease is the most common cause of Parkinsonism, but you have to recognize it can also be caused by drugs, such as dopaminergic antagonists, as well as toxins. So if you have a patient who presents with these symptoms, before you start thinking about Parkinson disease, you must exclude these others. About 85% of cases of Parkinson disease are sporadic. However, it is a familial disease that has really helped us to understand the pathogenesis. Because our lesions are due to a decrease in dopamine, treatment includes L-DOPA replacement therapy as well as deep brain stimulation. This brings us to the pathogenesis of Parkinson disease, which is quite complicated. It is believed that impaired lysosomal function is a central feature. Now, one of the characteristic features of Parkinson disease is going to be the accumulation of the protein alpha-synuclein, which typically regulates synaptic transmission. In Parkinson disease, we will see aggregates forming what is called a Lewy body, and it is believed that these have neurotoxicity. These too can spread from one neuron to the next. A second aspect of the pathogenesis of Parkinson disease is mitochondrial dysfunction, and we learned about this because of some autosomal recessive forms of Parkinson disease. Typically, when a mitochondrion is dysfunctional, we will get translocation of the protein PINK1 to the outer membrane of that mitochondrion. PINK1 will then recruit and phosphorylate Parkin, leading to the clearance of that dysfunctional mitochondrion. When we have mutations that knock out PINK1, we can get Parkinson disease, and it's thought this is due to the accumulation of these dysfunctional mitochondria, which can be releasing reactive oxygen species, etc. And then finally, defective proteolysis is believed to play a role in the pathogenesis. There are three pathways by which proteolysis can occur within the cell. It can occur through the role of molecular chaperones, through the ubiquitin proteasome pathway, and through the autophagy and lysosomal pathway. And it's thought that because of this defective proteolysis, we're having abnormal protein clearance of our alpha-synuclein. And part of our recognition of this has been that there are three proteins, DJ1, PINK1, and Parkin, that form a protein complex that degrades unfolded and misfolded proteins. And we see mutations in this in autosomal recessive forms of Parkinson disease. So this brings us to familial Parkinson disease, which can be due to point mutations or amplifications of the alpha-synuclein gene. We can also see it with heterozygous loss of function of the enzyme glucocerebrosidase. As you may recall, when we have homozygous loss of function, this leads to Gaucher disease. The role of glucocerebrosidase, which is a lysosomal enzyme, is thought to relate to abnormal metabolism of alpha-synuclein, perhaps to the unfolded protein response or increased inflammation. There is another gene, LRRK2, in which gain-of-function mutations can also lead to familial Parkinson disease. We do not know the function of this protein. And as I mentioned earlier, autosomal recessive mutations in the genes that encode the three proteins involved in proteolysis can also lead to familial Parkinson disease. Morphologically, the most classic finding will be pallor of the substantia nigra and locus ceruleus. Microscopically, we can see the cytoplasmic inclusions of alpha-synuclein, called Lewy bodies, in viable neurons, and then there will be associated gliosis, which is a response to injury. Here are a view of some images from Robbins and Kumar Basic Pathology showing the substantia nigra in a healthy individual and the extreme pallor in an individual with Parkinson disease. Here you can also appreciate a high-power view of a beautiful Lewy body here within this pigmented neuron. And then just one more example, you can see at lower power our diminished numbers of our pigmented neurons, and this one here has a beautiful Lewy body. As always, here are some questions so you can review the material covered in this video. As always as well, thank you very much for your time and attention. Please do subscribe, I sure would appreciate it. Thank you very much.